So one of the key points is that with neoadjuvant dual HER2-directed therapy, we're seeing extremely high total pathologic complete response rates. So for patients whose tumors are greater than 2 centimeters or who are node positive, dual anti-HER2-directed therapy with trastuzumab and pertuzumab, either with a taxane, carboplatin backbone, or with the anthracycline, Cytoxan, then taxane backbone, have shown to be very effective and are the optimal choices of therapy for those patients. One of the questions in the neoadjuvant treatment right now is the need for the dual anti-HER2 targeted therapy in patients who don't meet the present criteria. That is, patients whose tumors are less than 2 centimeters and who do not have lymph nodes positive. As Dr. Carey's study is showing us, these patients that are ER negative that have the HER2 enriched phenotype, they are a much more aggressive phenotype. And it may be that even these smaller tumors are the ones that will need the dual HER2 targeted therapy, whereas the more luminal HER2 based tumors may not need that dual targeted therapy. So I think there are still many questions that remain to help us decide who really needs the full court press with its attendant complications. Pertuzumab causes severe diarrhea in some patients, and of course the cost issues. So I think we need science to help us discover those biomarkers so that we can really give the patients who need maximum therapy that. Perhaps we need like a 21 gene recurrence score for HER2 to find out who are the really bad HER2s and who are the good HER2s.